All right.
Good morning and good afternoon. I am Deborah Cohen, volunteer moderator, pediatric endocrinologist within the MAVEN project, and I welcome you to today's session on global strategy for asthma management and prevention by Dr. Daniel Ray, and this is in partnership with Direct Relief. It's my pleasure to introduce today's speaker. Dr. Ray recently retired after 30 years in practice as a pulmonary and critical care specialist at North Shore University Health System in Evanston, Illinois. He was appointed assistant professor of clinical medicine at the University of Chicago and was the division head of pulmonary and critical care medicine at North Shore for 11 years. In addition, he was the medical director for the medical intensive care unit at Glenbrook Hospital and the respiratory therapy departments at Evanston and Glenbrook hospitals. He was active in medical education, teaching medical residents throughout his career. Dr. Ray, I'll have you begin.
Okay. So I'm using the slide set from this Global Initiative for Asthma because they make wonderful slides. Let's see if I can advance this. I don't have any disclosures. It's straightforward. Treatment of asthma, the goals are fairly simple, right? We want to reduce their symptoms and we want to reduce the risk. So symptoms, are obviously wheezing and shortness of breath, sleep disturbances, exercise limitation. The risk reduction is a little more vague. So there can be long-term decline in lung function with untreated or poorly treated asthma. Obviously, exacerbations take their toll on the patient, and then there's asthma deaths. And then patients have a significant number of side effects from all the medicines that we give them. What's interesting is sometimes the patient goals are very different than this. Primarily, the cost of the medication is these inhalers are so expensive that they often will modify your prescription to minimize their expenses. I'm sure you do this already. We use this kind of virtuous circle of assessment and review and keep making adjustments to their therapy to match so that their treatment matches their symptoms, minimizes their side effects, et cetera. So we want to be sure that we've actually confirmed the diagnosis. Oftentimes you'll be getting these patients handed down to you with a diagnosis of asthma. And maybe some of them don't really have asthma, or they have COPD more than asthma, or they have some other problem that has not been addressed. Comorbidities, obviously obesity, sleep apnea, gastroesophageal reflux can have an impact on their asthma symptoms. They may have modifiable risk factors. Another smoker in the house, cats and dogs that have the run of the house, including the bedroom, sleep with the patient, water damage, things like that actually can be mitigated to some extent. I've never actually been able to get a patient to get rid of their cat or their dog for even though they may have allergies to it. But I have been able to get them to close the bedroom door and keep the animals from sleeping with them. A key part of your assessment is going to be the patient's technique using the inhaler you've prescribed. These inhalers are complicated and patients often get them wrong. And even if they get them right once in your office, when you come back and reassess them, they may get it wrong the next time. So it's always worthwhile having either yourself or your assistant checking their inhaler technique every time they come in the office to be sure they're using it correctly. And then obviously there are the patient preferences, and again, you have to get into the weeds with what is the medicine costing them? Are they actually able to buy this medication? We obviously make adjustments based on these things, and we're sliding up and down that stepwise treatment for asthma depending on their symptoms, and then bringing them back or having somebody call them to review what the effect of this treatment has been. So here's the relatively new guidelines for stepping up therapy. There's a preferred track one that you can see that where we're using this combination, a low-dose inhaled corticosteroid and formoterol, so basically Symbicort or Symbicort generics, of which there are now several. And we're using that not only to as a reliever inhaler if they're having acute symptoms, but we're using it for its maintenance as well. So this is now the preferred step up in therapy. If for whatever reasons you can't get the inhaled corticosteroid formoterol generic, or the Symbicort is not on the patient's formulary, you can use the older track 2, but it does have one modification, which is that every time somebody uses their albuterol inhaler, they use a steroid inhaler as well. So they use their albuterol, then they should use their Flovent. So they should have these 2 inhalers instead of just using the albuterol again and again and again, as many of our patients do. The rest of that step up in track 2 is very similar to in the past, where we start with initially just symptom relief, and then a maintenance low-dose inhaled corticosteroid, and then going on to a combination inhaled corticosteroid and long-acting beta agonist, and then upping the doses of the steroid components, and then referral to allergy or pulmonary. So I'll go through this in a little more detail. Next slide. So in this new paradigm for asthma treatment, we're basically just using one inhaler, which is this combination inhaled corticosteroid formoterol. And for the mild asthmatic, the one that's only having occasional symptoms, or the one that's having symptoms maybe 2 or 3 times a week, they can use this on an as-needed basis as many times during the day as they need. So it would be very much the same as the way they use their albuterol inhaler now. So they have symptoms 2 or 3 times a year, say when they get a cold. Otherwise, they're fine. You would have the patient have this combination inhaler. If they start to have the onset of their cold, they would begin using this when they felt symptoms of chest tightness or wheezing. They would use it 1, 2, 3, 4 more times a day if necessary. And then as the symptoms resolve, they would slow down and stop their use, and just using it when they're having symptoms. If they're having ongoing symptoms multiple times a week, nocturnal awakenings, etc., then they're stepping up. This would be your step 3. And there they would be on a maintenance dose of the same inhaler, 1 puff twice a day. And if they're breaking through, they would use the same inhaler as their reliever. Same thing, if symptoms are more persistent, then they would double up the dosing. They would be taking 2 puffs twice a day. And then past that, we'll get into treatment of the resistant, difficult to treat asthma. But it's the same inhaler, same one you use to relieve symptoms that you use for maintenance. If you're not able to do that for whatever reason, and usually that's insurance-related problems, you can't get prescription covered, then they can use their albuterol inhaler, but when they do, they should be taking a puff of their steroid inhaler. So intermittent asthma, same thing. So they occasionally use an albuterol inhaler. Well, now they should occasionally be using an albuterol inhaler with their short-acting beta agonist. In step 2, when they're now taking their Flovent twice a day, for example, they would also, and they start to have more symptoms, they want to use their albuterol inhaler, they should also use the Flovent inhaler. And then by step 3, most of the patients are on a combination inhaled corticosteroid and a long-acting beta agonist like Advair. They would be using that twice a day as prescribed, but then as for relief, they would use their albuterol, and then they would take a Flovent puff with that, however many times a day it's required. So this is the old therapy, except that the albuterol gets paired with an inhaled corticosteroid. Actually, in Europe, they have these combinations of albuterol plus an inhaled steroid, and they will be coming to the United States, but it's not here yet. The other treatments you can do for patients that are having ongoing symptoms despite use of their inhalers would be the addition of a leukotriene receptor antagonist like montelukast. The allergist may have put them on sublingual immunotherapy. And by the time you've got them to high-dose inhaled corticosteroids, you could consider one referral to allergy or pulmonary, but you could also, in severe patients, consider addition of low-dose azithromycin. So this would be 250 to 500 milligrams 3 times a week for a month to several months, depending on their symptoms. And then, or you could consider the addition of a long course of oral corticosteroids. So you're going to be using oral corticosteroids for acute exacerbations with severe symptoms, but you could, in these very severe patients, occasionally we'll have them on longer courses of prednisone. Try to avoid this because of all the obvious side effects. Those patients, these step 5 patients, should have a referral to see the specialist. Just for terminology, you'll see this shifting in the literature. So we're trying to get away from the use of the term your reliever inhaler. Now it's an anti-inflammatory reliever. Obviously, if you're using a steroid, that's an anti-inflammatory, and then that combined with formoterol or combined with albuterol, for example. And then once they're on a maintenance therapy, that's a maintenance and reliever therapy. So the same inhaler, the inhaled corticosteroid formoterol, but you're using it both as your reliever inhaler and as your maintenance inhaler. So that's that maintenance and reliever therapy, MART, or sometimes you'll hear it referred to as SMART, which means single maintenance and reliever therapy. It's the same thing. I'll briefly review some of the evidence, which is building rapidly. So if you look at mild asthmatics, so this would be steps 1 and 2, mild asthmatics, comparing low-dose inhaled corticosteroid and formoterol versus as needed short-acting beta agonists like albuterol, there's a marked improvement with reduction in exacerbations. If you compare this low-dose inhaled corticosteroid formoterol on an as-needed basis against continuous low-dose inhaled corticosteroid and as-needed short-acting beta agonists, so what would ordinarily be standard therapy for your step 2, 3 patients, the symptoms are similar, but you have a reduction in severe exacerbations and emergency room visits when you use this low-dose inhaled corticosteroid formoterol on an as-needed basis when you compare it with daily inhaled corticosteroids and PRN albuterol. So you get a reduction in exacerbations. You get a reduction in the dose of inhaled corticosteroids that you're using, and patients like it. And basically, what your patient is doing most of the time at home is just that. They're using their inhalers more when they kind of feel like they need them and not so much when they're feeling fine. So this actually fits well in questionnaires. The patients prefer the as needed use as opposed to continuous use of an inhaler. So this is relatively new, the combination inhaled corticosteroid short-acting beta agonist. A variety of studies that showed a similar benefit to that we also see with the inhaled corticosteroid formoterol. The use of the inhaled corticosteroid formoterol compared with um, uh, the control group, which would be standard therapy, there's a marked improvement compared with higher doses of or regular combinations of inhaled corticosteroids and LABAs, um, like we'd see with Advair, for example, our asthmatics on getting treated with Advair and then using albuterol as a rescue. The SMART therapy, the use of the inhaled corticosteroid formoterol, both as maintenance and reliever, it's improved. So overall, you get a much better result using the SMART therapy as you do with the what were conventional therapies prior to this. This is just that New England Journal article that looked at the combo inhaled corticosteroid short-acting beta agonist. Again, as a rescue inhaler, there was some improvement. So how do we do this on a practical basis? You have your budesonide formoterol inhaler, one inhalation as needed for symptoms. So they can take it, and that's for steps 1 and 2. They can take it whenever they want. They can take more than once. So if they use it and 10 minutes later they're still feeling tight, they can use it again. When you stepped up to step 3, you're taking one inhalation twice a day, plus use in between if they need for symptoms. By steps 4 and 5, you're doing 2 inhalations twice a day, plus PRN use of it. The things to consider is in the same way you use an albuterol inhaler before you go exercise or before you're going, say, to Aunt Joanne's house and she has cats, and you know that every time you go there you start wheezing. You would take your albuterol. In this case, take the inhaled corticosteroid formoterol before you go visit. How much can you take? A lot, actually. So budesonide formoterol, maximum 12 inhalations for adults, 8 for children in a 24-hour period. So you can use it just more or less as you would an albuterol inhaler. You might get it might be difficult to get buy-in with your patient. You know, you'd have to ask them to try this instead of their albuterol, which they're probably by the time you see them, they're wedded to it. And you may need to change your action plans. So your action plans don't really reflect the SMART approach to treatment. On this link that you see here, you can get this action plan that does reflect SMART therapy. It allows the patient to step up their treatment if necessary, and then obviously when going between asthma to flares to emergencies. I am an adult pulmonologist, so I didn't see children. I'm going to kind of go through these slides because I know a lot of you do treat children, but I don't have any personal experience with this. The data that has accumulated has mostly been in adults, so we don't have a lot of data with children, and as such, the step up in therapy has not changed as much. For children, There is some evidence, though, that's accumulated children 6 to 11. So it is permissible to use a combination inhaled corticosteroid formoterol as your reliever um, in these patients in this age group, so school age children. Um, the Probably more commonly what you would do is have them use a, a low dose inhaled corticosteroid whenever they use their short acting beta agonist. Um, and then, step two, they're on a daily inhaled corticosteroid. Of course, their parents are controlling this, so they're more likely to get it. And then, but on a as needed basis, I've lost my cursor, um, you would use their albuterol and then have them take a separate a steroid inhaler, or else switch them over to this inhaled corticosteroid formoterol as their reliever therapy, as their rescue therapy. Um, by the time you're at step 4 and 5 on the children, they should have a referral in, because uh, uh, they are probably going to need significant doses of inhaled corticosteroids, which will have effects on their growth and other issues. For young children, so preschool children, again, very little evidence now or data with these newer treatments. So for children that have infrequent viral wheezing and no interval symptoms, you may already be doing this. You could consider a short course of an inhaled corticosteroid at the time of their illness. If they're having more frequent episodes, several times a year, and it seems like they have asthma, then they can use daily low-dose inhaled corticosteroids. The doses of this, of course, are different than adults, and then a short-acting beta agonist as their reliever therapy. And then by the time they're step 3 or 4, they should have a specialist referral in addition to their inhaler treatment. Key for kids is the inhaler technique. They should be using spacers. Their parents, especially at this age, should be administering the medication. You've seen this. I mean, the types of inhalers there's a plethora of different types. They all have slightly different techniques. There's the dry powder versus a meter dose inhaler. So you have to be familiar with this, and so that you in turn can observe your patient use the inhaler. So have them use it in the office while you're watching to make sure that their technique is good. So what do you do when you're having trouble with your asthmatic? So you either get a person that's had multiple exacerbations in the last year, or your patient is you've been stepping up therapy and they're still having ongoing wheezing symptoms. They've been to the hospital twice or in the last few months. So the things we begin to look for would be that first, what's their inhaler technique? Are they actually using it correctly? Are they using the prescribed dose, or are they kind of skimping on it because they can't afford to get another inhaler? Their comorbidities, obviously, are they playing into this? Do they have a significant GERD? Are they terrible obstructive sleep apnea? Or they have what I would see often was patients with significant atopic sinus problems. So you'd look back in your throat and you'd see the mucus draining down the back of their throat. You'd look in the nares and you would see big, boggy nasal mucosa. So in those patients, the sooner you get their sinus disease under control, the easier it's going to be to treat their asthma. So nasal irrigations, nasal steroid sprays, antihistamines, or going over to the allergist to be treated as well. Um, the If you've done all that, they're on moderate to high dose of inhaled corticosteroid plus the long-acting beta agonist, whether it be smart therapy or kind of our standard therapy. You could consider the addition of a long-acting muscarinic antagonist and or consideration of the leukotriene receptor antagonist. If, despite all that, the patient is having ongoing symptoms, then at that point they should be referred. And what your specialist is going to end up doing is just a $1 million workup that's going to include the blood count, looking at their eosinophils, their IgG and IgE levels, skin tests for fungal precipitants like aspergillus. They'll probably end up getting a high-res CT, looking for evidence of bronchiectasis, bronchiolitis, and then they'll be based on this information, they'll be assessing whether or not the patient has evidence of this type 2 airway inflammation, so that's eosinophilic-driven airway inflammation that might be amenable to the new biologic therapies. So these are the injectables, the monoclonal antibodies that either affect the interleukins that are produced as part of this inflammation or directly affect the eosinophil function. So if they're a candidate for this and their insurance allows it, and this is quite a process to get approval for any of these medicines because they're incredibly expensive, then the patient may begin treatment with that. If they don't have evidence of this type 2 inflammation, then they're back to the things that we'd already talked about, the addition of a muscarinic antagonist, low dose azithromycin. There is this thymic stromal lymphoprotein cytokines that there's a new monoclonal antibody that has been used in this. But again, that would be in the realm of what the allergist or pulmonologist might be able to prescribe. They're going to get these treatments, these specialized treatments. Most of the time they run for about a year. The patient generally gets better, and then they come back to you. And what happens is that, of course, they're off these treatments now, and this is when they flare. So be aware that, they may have done great when they were seeing the allergist. They come back and they start having symptoms again. It's not your fault. They've actually looked at this. When patients are withdrawn from these monoclonal antibody therapies, they have a much higher incidence of exacerbations. The other few things, I suspect you have patients that you're also treating for AIDS. So you're treating, there are drug interactions between salmeterol and vilanterol with these antiviral agents. So be aware of that. You probably need to modify, basically take them off of these. You can, this is actually a great place to use the ICS formoterol because it doesn't have that same interaction. And I have some example cases that we can go through, but actually just wanted to review the differential diagnosis. I was doing this with a group yesterday. Most of the time you have a patient with asthma, they have asthma. You've documented they have reversible airflow obstruction, they wheeze, you treat them, they get better. But sometimes then your patients aren't that straightforward. They don't necessarily wheeze. They have chest tightness or some shortness of breath. It sounds kind of asthma-like, but you haven't heard the wheezing. Your office spirometry, is just kind of equivocal. They don't really have a lot of obstruction. So you may end up treating them like asthma because you're not sure what else it could be. But it's a good time to step back and consider the differential diagnosis, and which is considerable. So a lot of patients with asthma have grown up around smoke, have smoked for some amount of time, and they may have this asthma COPD overlap. So they may have features of COPD, irreversible airflow obstruction, in addition to cough and intermittent episodes of chest tightness and wheezing. So depending on where they tend to fall in that spectrum is how we treat them. So if their symptoms are more asthmatic-like, we tend to target the asthma as the primary treatment. If they're more COPD-like, then we treat them as if they had COPD. Asthmatic bronchitis. So sometimes these people can get chronic infections, especially with Haemophilus influenza. In addition to their asthma, that's probably where the treatment with azithromycin actually has an effect. Bronchiectasis is common as in an overlap. These patients will have lots of respiratory symptoms that sound like asthma, but on the high-res CT, you'll find evidence of bronchiectasis. ABPA, you'll see occasionally. Terrible asthma, coughing up mucus. They'll have central bronchiectasis on their CT scan and have these marked serum precipitants, aspergillus. Hypersensitivity pneumonitis. So this is, your pulmonologist's favorite diagnosis. Somebody exposed to organic antigens that are aerosolized. They develop the severe inflammation in the lung. They'll have lots of respiratory symptoms and may get treated as asthma when indeed they actually don't have asthma. They've got a hypersensitivity condition. Our older patients with longstanding hypertension might have some mild underlying congestive heart failure, and they'll wheeze and be short of breath, but it's related more to their heart failure. And then thing to watch out for in patients that are particularly difficult to treat, have lots of chemical sensitivities, younger, mostly women. This would be the vocal cord dysfunction. So you can get a clue to this in that they're often they're difficult to treat. Two, that on examination, the wheezing may tend to localize more centrally, and you can hear inspiratory sounds as well as expiratory. Sometimes you can distract them and you'll get changes in the sound that they're generating in their chest. And then if you do spirometry, oftentimes they don't do a very good job of spirometry at all, but you may begin to see some mild upper airway obstruction, some flattening of the inspiratory loop as a clue. So this is difficult to treat. We have these people seek psychologists and voice speech therapists, but they don't really have true asthma. So that's giving them more and more inhaled medication and or steroids does not help at all. So I think there's time for questions. I'm happy to, and if anybody has any cases, they kind of generic kind of cases they want to discuss, I'm happy to do that as well.
Dr. Ray, you have a number of questions in the Q&A. The first question is, there's no longer any use for albuterol. Is that albuterol alone? Is that right?
Yes, that's pretty much right. Unless you can't, well, I say that, no. So in the severe asthma attacks, patients going to the emergency room, we're going to use albuterol. They'll get, tons of albuterol, and they can do the same thing at home. But no, we're trying to get away from that. We're trying to treat the inflammation as well as the bronchoconstriction. So just unmitigated bronchodilator, it doesn't do anything for the inflammation. In fact, it decreases the sensitivity of the beta receptors so that the albuterol fails, stops working. Patients develop tachyphylaxis to it. So it's a vicious cycle. The more they use it, the less effective it becomes.
Okay, thank you. And the rationale for azithromycin, what are the effects results when compared to a course of oral steroids?
So oral steroids are going to be your go-to for severe exacerbations. No question about it. That reduces inflammation. The azithromycin would be in your patients you're having difficulty with their long-term control. So they may not be, not in an acute setting, but in long-term control. You don't want to put them on long-term oral corticosteroids. You may want to try uh, a several month course of azithromycin. Be aware that that can be associated with tinnitus and hearing loss. So when we use this, we will get an audiogram and then repeat it in a month when they've been on the medicine, and advise the patient if they're having ringing in their ears to call you or to stop it.
So, when would you choose the azithromycin 3 times a week
So
versus
just
the long-term oral steroids?
oh, so I would try the if my patient is not in the middle of an acute exacerbation, I might try the azithromycin first. If my patient has been, and mostly what happens is the patient has a severe exacerbation, so we taper the steroids, they start to have a recurrence of their symptoms. So we bump the steroids back up, and then pretty much they're on steroids for a long time. At that point, you may want to add the azithromycin and see if you're able to taper off the prednisone.
Okay, thank you. Another question. What is the time between doses for the as needed ICS formoterol? That is every 2, every 3, every 4 hours.
No, you can use them back to back, just like you use albuterol. If in a few minutes you haven't had some relief, you can use another dose. So
Okay.
it's fast. So the benefits of formoterol is it's fast acting, even though it lasts, a longer. It's a long acting beta agonist. Um, so the patient should begin experiencing a relief within minutes if they're going to get relief from that dose.
Okay, thank you. The next question, for patients that have a blend of asthma and COPD, can they try Symbicort as first line for exacerbations?
Yeah, absolutely. Yeah. So in COPD, in pure COPD, we tend to start with the muscarinic antagonist and reserved inhaled corticosteroids for a select group that have elevated eosinophils or recurrent severe exacerbations of their COPD. So the use of inhaled corticosteroids in COPD is much more limited and for a select group. In asthma, in this case, we're using inhaled corticosteroids for everybody at almost at every level.
Okay, next question. At what age can we order pulmonary function tests, starting at 5, or what do you suggest?
For monitoring asthma, so that's the thing. You can get PFTs at almost any age. The validity of the PFT, kind of drops off at the younger ages because they can't exactly cooperate with the test. Um, so, and I just don't know in pediatrics because I didn't do it. I know we've done PFTs in teenagers and that seems to be fine. I just can't tell you about school age children, how well they do.
Okay, no, I think that's fine. And let's see, Jody McGill, you have a question, and I believe I've unmuted you.
Hi.
No, I'm fine. Thank you. I didn't have a question.
Oh, you didn't have a question. Okay.
No, thank you.
Thank you. That's okay. Let me go to the next Q&A. At what age can we start inhalers instead of nebulized treatments?
Oh, that's kind of in that pediatric realm.
Yeah.
Yeah, I'm not sure, actually. Having not done it, I just don't know.
No, that's perfectly fine. The next question is, how can we diagnose asthma in primary care? It sounds like the differential diagnosis list is large, and most of that testing would be done by a specialist. But is asthma diagnosed clinically in primary care, or what is the role of PFTs?
Yeah, so great question. So most of the time, you don't need a complete set of PFTs to diagnose asthma. In fact, spirometry is fine, and it is a clinical diagnosis, and you are going to make the diagnosis, 99% of the time, based on the patient's history of recurrent, respiratory symptoms, the wheezing that you hear on exam, obstruction on office spirometry, response to therapy. So if you have those, history of allergies, history of recurrent respiratory symptoms that come and go, wheezing that comes and goes, response to therapy, obstruction that improves with bronchodilators on spirometry, any kind of
We don't
combination of
do,
that.
I mean, so you're saying the spirometry that we have
Yeah,
is enough to, with a trial?
But we have a PFT machine.
Yeah. But he's saying to do it with a trial. So you,
oh, you can, in the office, if you do spirometry and they have some amount of obstruction, definitely have them take albuterol and wait, 5 or 10 minutes and repeat it and see that if you get a significant improvement. That would be almost a sine qua non for asthma.
Okay, I'm going to go to the next question, which is, will Medicare and Medicaid pay for these medications without prior authorizations?
So yes, they will. So yeah, Medicaid's actually pretty good about this, and they have, as I said, they're generics now for the ICS formoterol combinations.
Okay, next question. Have you seen long-term worsened asthma after a COVID infection? If so, any way to get them back to their baseline prior to COVID?
Yeah, that is a great question. So yeah, and I don't have a good answer for that. It's not asthma. So the post-COVID respiratory symptoms that people have, the shortness of breath, they don't always wheeze, but sometimes, but they never get back to their baseline. And we've tried treating them with inhalers and, with mixed results. It's not clear if it's just time that they get better. We think that there's microthrombosis that occurs in these severe infections that may damage the lung or the pulmonary microvasculature. I don't have a good solution to that. There are a few cases in the immediate month or 2 months after a COVID infection where they can have ongoing inflammation, but sometimes they'll respond to dose of steroids. That would be detected on CT scan, and so, but I don't is a give them a Medrol dose pack as a trial. I can't recommend it because I don't think there's any good information that it helps or it doesn't help. It's just we don't know.
Okay, thank you. Next question for patients with asthma COPD overlap and on an ICS LABA LAMA. Do you
Right.
advise breaking it up with a daily long acting and as needed ICS LABA?
Not for the asthma COPD overlap. Again, those patients weren't included in the studies with the SMART therapy, so I would reserve that for your asthma patients. I think the standard therapy with the triple combination inhaler, there actually is really good evidence for improvement in COPD in those patients, so I would stay with that.
Okay, next question. I tuned in late. Did you discuss the apparently poorly recognized psychiatric side effects of montelukast?
I did not, and so I'm glad you brought that up. So there is a black box warning for suicide with Montelukast. We tended to get away from it from that perspective, and also, at least in my personal experience, I didn't see that it made much difference. So it's one of those add-on therapies if you're at wit's end and having difficulty controlling the patient.
Okay. What complications have you seen in pulmonary with COVID and long COVID?
So just as we were talking before, um, the well, shortness of breath, one, poor exercise tolerance, persistent hypoxia, and then on CT scan, we'll see signs of scattered signs of inflammation that is long lasting. I mean, CT scans that over many months where there's still persistent ground glass attenuation, some heterogeneity in the density of the lung, things like that.
Okay. Next question. If someone is already using a steroid inhaler, how is that likely to impact confirmatory spirometry?
It decreases the airway responsiveness to bronchial. I'm sorry. They'll have it will interfere with their the difference between their pre and post bronchodilator results. So in other words, it improves their asthma, so they're less responsive to bronchodilators on the test. So yeah, it'll, if you really want to know and you're uncertain about it and they've been on a steroid inhaler forever and you're really not sure if they have asthma or not, take them off the steroid inhaler, wait a few days or a few weeks, and then test them at that time.
Okay. When in your algorithm do you get a CT scan? What red flags trigger a CT?
Oh, well, see, I'm a pulmonologist, so we're ordering CTs all the time. So it's really not. If you need a chest CT, if you're concerned that there's something else going on, go ahead and get a. You can actually get the low dose CTs are also high resolution CTs, so you can get a low dose CT on the patient, and while you're waiting for a referral. But at that point, if you're ordering a CT, I'd probably order a referral.
Okay. Thank you. With the increased use of inhaled corticosteroids, do you see an increase in oral thrush? I have a patient that states she rinses after each use but keeps getting thrush. How do you manage this?
So great question. No, actually, I was looking at this. When you're using this combination ICS formoterol on an as needed basis, I guess because it's not a continuous use, in the follow-ups, it's like 30,000 patients, there was no increase in thrush in those patients. Patients that are on maintenance therapy, or getting daily inhaled corticosteroids, should be doing the rinse and spit. For this particular patient, sometimes they don't gargle, they just kind of swish around the front of their mouth and spit it out. They need to actually gargle and then spit. And then sometimes if they're still having thrush, then I'll have them gargle with an nystatin on a daily basis to try to cut down thrush.
Okay.
And also, last thing on that is make sure they're using it correctly. And also that if they have a meter dose inhaler that they're using with a spacer, that'll decrease the deposition of the inhaled corticosteroid in the back of the throat.
Okay. In your experience, how does inhaled corticosteroid long-acting beta agonist use, as needed use, compare to inhaled corticosteroid short-acting beta agonist use?
So that study hasn't been done. The head-to-head of inhaled corticosteroid formoterol versus inhaled corticosteroid albuterol. The inhaled corticosteroid albuterol studies are brand new. I mean, in the last few years, the inhaled corticosteroid formoterol studies are, that go back now for about 10 years, and they're accumulating still. So we have a lot more patients, tens of thousands of patients in the inhaled corticosteroid formoterol studies, as opposed to the few hundred patients in the inhaled corticosteroids albuterol studies, and we haven't had a head-to-head. In terms of the groups, the comparative effect, it seemed to be the same. So inhaled corticosteroid formoterol was better than daily inhaled corticosteroid and PRN albuterol. In the same way, inhaled corticosteroid albuterol was better than inhaled albuterol alone. So we don't have inhaled corticosteroid short-acting beta agonist maintenance therapy studies at all.
Okay. Do you use a peak flow meter to monitor response to therapy or to gauge severity of exacerbation?
I don't. We had an office spirometer, so we used the office spirometer as opposed to peak flow meter. And there was for many years on the patient's action plan, they would have their own peak flow meter at home and that they would use. I thought that those were wildly inaccurate and very effort dependent. So my preference was just to base the action plan on their symptoms and not on their peak flows.
Okay. Do you give probiotics when you're prescribing long-term azithromycin?
No, we didn't.
Okay. Do
We
you have
had
a
lots of different
concern about-
patients. I'm sorry, we had lots of different patients on long-term azithromycin, for a variety of other respiratory conditions. So no, and it didn't seem to be necessary, especially at the lower dosing, the 250 Monday, Wednesday, Friday, really well tolerated. The question is how long would the patient need to be on that, and then this issue about hearing, and the COPD studies that were done with it, roughly 10% of patients had some effect on their hearing. So that's a significant number. So not to be taken upon lightly, but these patients are, especially in the asthma realm, are very sick. I mean, they're just daily severe symptoms not controlled on, high dose therapies.
Okay, thank you. 2 more questions. Have you seen worsened asthma, either short or long term, after the COVID vaccine?
I haven't. And I don't know of any reports on that, but I haven't looked either, so I can't give you a good answer.
And have you heard of any adverse pulmonary side effects to the COVID vaccine in general?
No, not pulmonary.
Okay. Do we have any other questions? You have 5 minutes. I don't know if you want to quickly go over one case or.
Oh, sure. Yeah.
Okay. I think that would be interesting.
All right. So you probably all recognize this patient. I mean, it's, just a generic patient, but this is, what we would see in the often frequently. So 45-year-old obese woman. She was an intermittent smoker, particularly when she was younger. She's on Medicaid, lifelong asthma. She's getting lots of short courses of oral corticosteroids for exacerbations, which are characterized by coughing, wheezing, shortness of breath. Currently is on LABA, inhaled corticosteroid, 500, the high dose, 550. She's on a LAMA. She's got albuterol inhalers and albuterol nebulizer. She's having worsening symptoms, wheezing on exam, and the office spirometry shows significant obstruction with an FEV1 FEC ratio of 50%. She does not want to go to see the specialist because she can't afford it, can't travel, can't take time off, whatever. So then the kind of this is the kind of where you just like, I'm doing everything. What else can we do? So it's a good time to step back and just to start from scratch again. So even though you've prescribed all these things, is she actually compliant with the medication? Again, money can be an issue. These inhalers often are quite expensive, particularly if they hit the donut. Um, so they may be cutting back, not taking as much as you've prescribed. You want to make sure that she's using the inhalers correctly. So you want to observe her use the inhaler to see if the technique is good. Question her again about exposures that might be modifiable at home. So, did somebody move into the apartment that's a smoker now? Or are there new pets, or are the pets, not under control? Do they have mold issues in their apartment? Have they got exposures at work that could be triggering them? And then we talked about these alternate diagnoses. Does she have some component of COPD? Does she have bronchiectasis, chronic sinus disease, GERD, heart failure? So you could start with some simple tests like a blood count, looking for eosinophils to suggest asthma allergies. This is, again, my bias. You start with a chest CT looking for bronchiectasis. You don't necessarily need to do that. I would probably walk this patient around with a pulse oximeter and see if she's desaturating. That would be kind of a red flag to me that there's things are worse than they seem. If she's producing sputum, I would try to catch some to see if she's got evidence of a chronic bronchitis or low-grade infection. Sometimes these patients will have an atypical mycobacterial infection in the sputum. And if she, because of her obesity and the asthma symptoms, I would wonder whether or not she's got significant sleep apnea. So I would ask questions kind of probing that and consider a sleep study. Treatment plan, daily peak flows are monitoring. So smoking cessation, obviously, if she's still smoking and she doesn't need to be, mitigating these environmental exposures, and then we talked about referral to a specialist for consideration of treatment of a type 2 inflammatory asthma with the biologics or treatment of chronic sinus disease. So that's just kind of how I might work through a case like this. I'll give you another patient, example patient, and we can kind of work through it together. So here's a 50-year-old male smoker with a remote history of childhood asthma. By the way, a lot of asthmatics will seemingly outgrow it and then pick up smoking as a habit. And so you always wonder whether there's some underlying reactive airway disease on top of their smoking and possible COPD. But anyways, this person's struggling with finances, drug abuse, frequent incarcerations, history of drug overdoses, including one recently requiring intubation and hospitalization for an aspiration pneumonia. Now he's coming in your office. He's increasingly short of breath. There's audible wheezing. He walks in, you can hear him wheeze. He's not smoking right at the moment. And he had already been given an albuterol inhaler, but doesn't seem to get any relief from it. So what other questions might you ask in this point? So because it's a large group and it's hard to get there, I'll ask some questions. So, his one question would be, is he abusing drugs again, particularly in inhalational drugs? And then another question, is he coughing or producing any mucus? And is his, does he have any new exposures? And say the answer to all that is no. what test or exam might be helpful? Well, an office spirometry. Most office spirometries only give you the expiratory flow loop, so you don't see the inspiratory flow loop. But on this particular person, it was fairly obstructed, severely obstructed, with an FEV1 that was only 45% predicted, and it was somewhat flattened. And on its exam, he seemed to have inspiratory and expiratory wheezing, and again, loud sounds that tend to localize more centrally. So at this point, what's my treatment plan? So I bet a number of you have already suggested that, well, does he have a tracheal stricture from his recent hospitalization and intubation? And the answer would be yes. A treatment plan would be a CT scan of his neck and chest, and also referral to ENT. So, okay, everybody good on that?
Okay. I think that was great. We have a couple more questions, which I think we'll pose to you separately, since we're at the top of the hour and I think people
Okay.
have to go back to work. So thank you so much for this very complete discussion. We had a lot of great questions, and
Good questions.
thank you everyone for tuning in. We had a nice big group. Okay, I'm going to go ahead and close the session today. Thank you for attending. I'll let you see all these nice comments first.